Good evening, students. So now this chapter is going to start with your surgery section. Okay, there are a few more chapters which are remaining in the non-surgical side, which will be covered by other teachers. But for right now, since my other topics are over, I'm jumping into the surgery side. So let's just start off with the principles of periodontal surgery, meaning what is the rationale? Why do we go into surgical side? Okay, why do we choose surgery over non-surgical phase? And what are the conditions that we look for? Okay, what are those pertinent findings that make us decide on periodontal surgery? And there are a few norms that you need to know before you enter this. And this is mostly on your clinical side, since you have not yet to do some patients. But this is a very layman way I can explain, okay, what has to be taken care of when you start this chapter. So let's start with the rationale, okay. Why do we go for periodontal surgery? It should be when the non-surgical method are not effective enough, right? So usually we say that when a patient comes to you, you give a provisional diagnosis and then you call him for, you start with your non-surgical phase, like your phase 1 therapy, and you ask for a reevaluation. You ask the patient to come back to you. And then you check again the particular findings. It could be clinical attachment loss, it could be probing depth, okay? Any of those periodontal factors and the parameters also. And when you check that these things haven't changed much from your previous findings, from your first appointment findings, that's when you realize that you need to move into the surgery side. Okay, so the first reason could be to access, for a better access for root preparation when non-surgical methods are ineffective, to establish favorable gingival contour. Just by scaling and root planing, you might not be able to establish the correct gingival contour after the disease state. To facilitate self-performed oral hygiene. Oral hygiene method should be easy for the patient to carry out by himself. And in case of crown lengthening, I'm sure you've heard the term crown lengthening when a patient comes to you, and somebody from the restorative department, it could be a crown, it could be FPD, or even an FPD after prosthetic rehabilitation after implant surgery. So in those cases, you need the clinical crown, enough clinical crown, right? And the crown root ratio should be correct. So in that case, when you have to remove the excess gingiva, they call for a crown lengthening procedure. And also to regain, obviously, when you need to do some regenerative procedures, such as bone grafting procedures or gingival grafting, or it could be laser surgeries, all those kind of things, you need to regain the lost periodontium using regenerative approaches. So for all this, the surgical side is when you approach the, when you actually go for a surgical option. Now, the patient has finished his phase 1 therapy, and you call the patient back for reevaluation. So what are you going to see? And during that scaling and root planing, or the first non-surgical phase 1, we eliminated some lesions entirely. We get the tissues to be more firm, consistent. So before surgery, this is what they are saying, but by scaling and root planing, how do we make the gums ready for a surgical phase? So we have to eliminate most of the lesions entirely, if possible, by scaling and root planing. We need to render the tissues. Tissues should be firm before you attempt any kind of surgery, because if it is soft or erythematous, or if it erythematous, it might tear, and then it becomes a further loss of gums. So in that case, you need to find the tissue should be firm and consistent, thereby allowing for a more delicate and an accurate surgery. And the patient also should be acquainted with the office, the operator, the dentician, and his or her assistants, just to reduce the patient's apprehension and fear. So these are the things that you need to keep in mind before we move on to a surgical side. As much as possible with scaling and root planing, we need to get these things achieved. Now, what does the reevaluation phase consist? A patient comes to you after phase 1 therapy, you recall the patient after 2 weeks, and what do we look for? We need to reprobe, we need to re-examine all those pertinent findings or all those periodontal parameters, okay? Like already I mentioned, CA, clinical attachment loss, pocket depth, recession, okay? There are so many things we look for, mobility. So all those findings have to be reprobed, re-examined, which were previously indicated when we thought that there is a need for a surgical procedure. And the persistence of these findings confirms the indication for surgery. So if all these parameters are not much of a change or does not show much of a reversion even after phase 1, that's when we call for the phase 2. The number of surgical procedures, the expected outcome, and the post-operative care, they're all necessary. All are necessary. They're all determined before the major surgery. Before you decide on surgery, all these things, how many procedures are you going to attempt? What would be the expected outcome, or what is the prognosis? And also the post-operative care after that particular surgery has been done. So all this should be determined way before the start of the therapy. Now, pre-medication. Some studies, they say that most of the teachers are against, or most of the clinicians are against antibiotic. Okay, so before the procedure. But some studies have reported that there is a reduced post-operative complications, which gives you reduced pain and swelling when antibiotics are given before periodontal surgery, and they're continued for 4 to 7 days after surgery. So what they're saying is that even I believe that when you're doing, especially if the patient has any comorbidities, like if it is a diabetic patient or if there's got some periodontal abscess, what we can give is, it is not necessary, it's up to you. We can give antibiotics, and during the course of the antibiotics, ideally it should be 7 days. Okay, according to theory, it is 7 days, but we give for mostly 5 days. So between 5 to 7 days, when we give him antibiotics, make sure that you proceed with your surgery during that course time. Okay, so that the bacterial load and the inflammation and the swelling and the pain, they all are on the low side when that happens. So the prophylactic use of antibiotics in patients otherwise healthy. But in case of the healthy patients, only if there is any bone grafting procedures. If you are attempting any bone grafting procedures, then you should give antibiotics, okay, which will enhance the chances of a new attachment. So make sure that in a healthy patient, there is no need for giving antibiotics, but only if in case you're attempting a bone grafting procedure or any regenerative procedures. But no research evidence is available to support this. And other pre-surgical medications are NSAIDs that we give ibuprofen 1 hour before the procedure. Most of these cardiac patients and all, before we attempt any surgery, they should be given 1 hour. NSAID should be given 1 hour, as well as use of, we give antibiotics also 1 hour prior to the surgery and 1 hour after the surgery. And also chlorhexidine gluconate. 0.2% low, that is pre-rinse and post-rinse, have to be given to the surgical patients. Precautions to be taken with medically compromised patients. That's why I said mostly with the comorbidities patients, we take extra precautions, okay, by giving them medications only if it is approved by their following clinicians or any other, whichever cardiac patient, cardiology has to give a consent, or any other department should give consent before we prescribe. Smoking. Now we already know, we have been learning from a long time. I mean, though we have a chapter on smoking. What happens if the patients are on still on smoking? Surgical patients after surgery, the healing of the periodontal wound, okay, becomes deleterious effect. It has a deleterious effect of smoking on the healing of the periodontal wound. That is why we ask the patient to stay off cigarettes while after the surgery for at least 3 to 4 weeks. Okay, because patient should be clearly informed of the fact, and he should be asked to quit smoking completely or to at least stop smoking for a minimum of 3 to 4 weeks after the procedure. For patients who are unwilling to follow this advice, an alternative treatment plan that does not include, that means basically you can stop at your phase 1. therapy, because there is no point in doing any regenerative procedures or mucogingival surgeries or aesthetic procedures for such patients, because healing is going to be hampered if the patient is going to continue smoking. So try to, you know, tell the patients to follow this advice. Informed consent. All of you have been doing ICMR projects and things like that for the last couple of years. So in all those cases, you have realized that you need to take an informed consent, because without that, what is an informed consent? It is verbally asking the patient and putting it in writing that he or she is ready, okay, for the particular type of treatment. You have already discussed the prognosis, you have already discussed how the outcome of that possible treatment is going to be, and you're ready to try it out. Okay, so the patient should be informed at the initial visit about the diagnosis, prognosis, and different possible treatments with the expected results and all the pros and cons of each approach as well. At the time of the surgery, the patient should again be informed verbally and in writing of the procedure to be performed, and he or she should sign the consent form, which is a necessity nowadays. Even in clinics, we are going to do it, because there's a good chance that nowadays the clinicians are easily sued, just like how in US and UK. It's very easy for a clinician to be sued, because if he ends up having a different outcome after the treatment, they immediately. So make sure that you have an informed consent, and even if it's a scaling, you put it down in writing. Patient has agreed to go through the phase 1 therapy. That has to be signed. If the patient is uneducated and he's not able to sign, you can use a thumbprint. Now, before any procedure, make sure you have the emergency equipment. It is not just for surgery. Even for scaling, I have seen in our departments, students easily go into syncope, which is the transient loss of consciousness, right? Because there is no oxygen flow. The blood pools in the legs and it does not flow to the brain. So all the there is less cerebral blood flow and oxygen to the brain. So this is a very common emergency that happens even not just in the surgical side, which happens in the non-surgical side also. So make sure all the drugs and equipment, and you know how to treat these emergencies. Other than syncope, you also have another major one is anaphylaxis. Make sure hypersensitive reactions to whatever LA that you administer or any kind of drug that you give, okay? Or make sure that you have a good idea of all these emergencies way before you start your procedure, and you should know the ways to tackle it, okay, on your own. Causes of syncope are fear and anxiety. Syncope is usually preceded by a feeling of weakness. So this is what you see in these patients. They develop pallor, sweating, they start sweating, they have coldness of the extremities, dizziness, and a slow pulse. For such cases, when the patient is lying in a dental chair, make sure that you put them in a supine position with the legs should be elevated above the head. Okay, they should be in a slanting position where the legs should be above the head. Fine. The tight clothes should be loosened, wide, the airway should be opened and widened, and the administration of oxygen is also useful. Unconsciousness may persist for a few minutes. I'm sure most of you are reading right now or listening to my the class. They've already been through this syncope, okay? Now, and another important thing when you're in your clinics is that how to prevent transmission of infection. Mostly we're talking about the danger of transmitting infections, particularly HIV cases and hepatitis B viral infections. And for these cases, you have to use universal precautions. If the patients have already been, he's a pronounced HIV patient or a pronounced hepatitis B virus patient, which is very rare. You might have a patient who doesn't know. Even take, for instance, your corona. So we also don't know if they are pronounced corona positive or negative. So in these cases, you have to use your universal precautions. Example, your protective attire, the barrier techniques, use your disposable sterile gloves, double-layered surgical mask, protective eyewear, all the surfaces possibly which can be contaminated blood and supply should be sterilized. Okay, the light, the handle, the unit syringes. Most of you have been to the first posting already and the second posting already, so you know we have to cover the lights, the switches. Everywhere that you touch normally on your dental chair should be covered with aluminium foil or plastic wrap. Aerosol producing devices, all your scalar tips should not be used on patients with suspected infections. Be careful, okay? Or your history. This is where your history comes into action. Make sure you take a proper medical history. As much as possible, dig deep and find out if the patient is, on any kind of drugs, or if he's already had any medical admissions which you don't know in the last 10 years. Make sure that you ask for the last 10 years. Special care should be given for disposing sharp needles, which I don't see most of you performing. You should be very careful when you dispose the needles and scalpel blades. You have a machine where you can burn them. Okay, so these are the few things that you need to, the steps that has to be taken to prevent transmission of infection inside the clinics. Okay. Sedation anesthesia. So before we attempt, will the patient be comfortable if you don't give them a proper LA, or if the patient is not anesthetized? So it will make your surgical, what do you say? I mean, you won't be thoroughly, you can't concentrate on what you're doing if your patient is, having pain and moving in pain, or he is having anxiety. Okay, so the means of providing a painless surgery is by effective administration of local anesthesia. The area to be treated should be thoroughly anesthetized by means of regional block, local infiltration. Injections directly into the interdental papillae may also be helpful. Apprehensive and neurotic patients, anti-anxietic patients, or sedative hypnotic agents and administration of these agents. And like that's what I said, and the anxiety drugs and hypnotic, I won't say hypnotic, there are conscious sedations we do, right? And we've already taken a CD on that pediatric side. So inhalation and oral intramuscular intravenous routes. So these things can be given through inhalation, oral intramuscular and intravenous routes. Least invasive method to alleviate anxiety is nitrous oxide and oxygen inhalation sedation. That is what I said, conscious sedation, safe, effective, and reliable means of reducing mild anxiety. You can even give orally benzodiazepine, which can be effective to decrease the anxiety. So make sure the patient is really completely sedated and comfortably anesthetized, so that it does not hamper your surgical, during your procedure as well. Now, so we're finished with the patient. You've put the patient on the chair. You have manipulated everything. You've taken care of him. You've anesthetized, and you're ready to go in. Now, but first you need to know the tissue management. Like already I told you how the tissue should be. If it is soft and edematous, it has to be firm. Then only you can attempt any kind of surgery on it. Otherwise, it might have a deleterious effect on the gums when you start doing a surgical procedure on it. You have to operate gently, carefully. Tissue manipulation should be precise, deliberate, and gentle. Thoroughness is essential, but roughness must be avoided because it produces excessive tissue injury. It is the softest tissue in your body. Okay, it's the most. What can you say? You can tear it at a whim's time. You never know. My HOD used to say it's the most forgiving tissue, because whatever you do, even if it's a small blade wound, it might tear, but it'll revert back to itself, to its original shape very soon. So make sure that your manipulation should be precise, it should be gentle, thorough, but roughness should not be rough on it, because it produces excessive tissue injury, that which can cause post-operative discomfort, and it may delay the healing as well. Observe the patient at all times. Make sure the keep your eyes on the facial expressions, your pallor, perspiration. Take a little bit of time after every step. Take some time to relax and see if the patient is relaxed. Ask him. Okay, so that if there is any facial expressions, you know that the patient is experiencing some kind of pain or anxiety or fear. Be certain that the instruments are sharp. Instruments must be sharp to be effective. You've already learned in principles of instrumentation, right? Should be sharpening. It should be sharpened so that it could be effective. Dull instruments will just inflict unnecessary trauma because of the result of poor cutting and excessive force. If it is a blunt instrument, you will put excess force on it, to compensate for their ineffectiveness. A sterile sharpening stone should be available on the operating table at all times. Scaling and root planing, even after phase 1 therapy, all the exposed root surfaces should be carefully explored and planed as needed as part of the surgical procedure. So even during the surgical procedure, you can still use your scaler tips to scale and root plane. In particular, areas of difficult access, example furcation, deep pockets, often they have rough areas or even calculus which are hidden or undetected during the preparatory sessions. Because when you're doing scaling and root planing with hand instruments or with scaler tips, there is a degree to how much you can penetrate, right? So when you elevate the flap, there is a more access to it. So make sure that you even do it in the surgical phase as well. During the surgery, make sure that the calculus which is hidden or undetected also should be removed, especially in the furcation areas or where there is deep pockets. Hemostasis, important aspect of periodontal surgery. Good intraoperative control of bleeding. So what do you mean by hemostasis? There should be very less blood field. There should not be any blood coming in, because if the field is full of blood, this hampers your vision. You're not able to perform your surgery well. So if there is a good intraoperative bleeding control, what will it give you? What are the pros of that? It will give you an accurate visualization and an idea of the extent of the disease. It will show you the pattern of bone destruction, okay, the correct anatomy and the condition of the root surfaces. And if there is less bleeding, it provides a clear view of the surgical site, which is essential for wound debridement, scaling, and root planing. Good hemostasis also prevents the excessive loss of blood into the mouth, oropharynx, and stomach. So we need to control the blood flow. Okay, that is what you mean by hemostasis. So this has to be there, because sometimes the blood can even flow into the mouth, oropharynx, and stomach. So we need to have a clear view of the surgery where we're doing, because you're doing with sharp instruments. So if the blood keeps hampering your vision, you won't be able to perform your 100% on your surgery. Okay. Periodontal surgery can produce bleeding, which is actually inevitable. So these things are inevitable. If there is bleeding, there is bleeding. So the control of intraoperative bleeding can be managed with aspiration. That is why you use a suction, right? Always keep aspirating that site so that the blood is sucked in, so that you have a clearer view of the field. Continuous suctioning of the surgical site with an aspirator is indispensable when performing periodontal surgery. So it is a need that a suction should be there when you're performing a surgery. The application of pressure to the surgical wound with a moist gauze can be an adjunct to control the site-specific bleeding. I don't know if you have witnessed or if you have assisted any kind of surgery. Most of you must have. So when you do that, you always see that we always use gauze. So gauze can also be used as an adjunct to control this bleeding. You can just moist gauze you can take and keep it there, so that the blood gets sucked into the gauze. So it is not just a suction, you can use moist gauze as well. You can even use a local anesthetic. Give that area a local anesthetic with a vasoconstrictor, which is useful for controlling minor bleeding from the periodontal flap. Okay. For a slow, constant blood flow and for oozing, hemostasis may be achieved with there are hemostatic agents. Example, absorbable gelatin sponge, gel form, oxidized cellulose, oxidized regenerated cellulose, microfibrillar collagen, hemostat. Just learn a few names: gel form, oxygel, hemostat, colacoat, colatape, colaplug. These are common actually, colaplug. They are useful hemostatic agents for the control of bleeding in capillaries, small blood vessels, and deep wounds. So if you feel it's unbearable and uncontrollable, you can even use hemostatic agents. You can use a local anesthetic with a vasoconstrictor and use a gauze and a suction. So these are things that will help you control the bleeding. It is imperative to recognize that excessive bleeding may be caused by systemic disorders. So in some cases, there will be excessive bleeding which we may not be able to control. That could be because of the comorbidities. That's why I already told you, systemic disorders, like the patient might, that's why we always say you should have a blood test, should have a complete blood hemogram before the patient walks into your chair for a surgery. Platelet deficiency should be ruled out, coagulation defects should be ruled out, medications should be ruled out. Now, if the patient is diabetic or hypertensive, all this should be ruled out in your medical history. All surgical patients should be asked about their current medications, family history of bleeding disorders, hypertension, BP evaluated before surgery. Okay, your blood pressure should be checked even before the surgery, and anyone who is diagnosed with hypertension should be referred to a physician before you attempt. Even a diabetic patient should be referred to his or her endocrinologist before you plan out your surgery date. Patients with known or suspected bleeding deficiencies or disorders should be evaluated. Consult with that particular patient's physician or have your laboratory test taken, okay, to assess the risk of bleeding. It may be necessary to refer the patient to a hematologist also. If there are any platelet deficiencies or coagulation defects you rule out, if you see the platelets are less, you have to refer to a hematologist as well. Now, after the surgery, now this was all done before the surgery. During the surgery, what you have to take care. Okay, before the surgery, what are the things you need to prepare? What do you have to prepare during the surgery? And now what is done after the surgery? So periodontal dressings, most of you know which are the periodontal dressings we use commonly. In most cases, after the surgical periodontal procedures are completed, the area is covered with a surgical pack. These pack, they assist in healing by protecting the tissue. Okay, mostly for grafting procedures and all, when we are attempting regenerative procedures, we make sure that the area, that is the donor site and the recipient site, mostly the recipient site, is covered with a periodontal pack so that that area, the tissue, is protected. The pack minimizes post-operative infection, hemorrhage. It facilitates healing by preventing service trauma during mastication. Okay, because that area is susceptible to any kind of trauma due to mastication, right? So this pack will help it to prevent it from getting traumatized. It protects the patient from any kind of pain induced by contact of the wound with food or with the tongue during mastication. Now we have two types of dressing. We have zinc oxide eugenol and zinc oxide non-eugenol. Okay, the packs that are based on the reaction of zinc oxide and eugenol include the Wonder Pack, which was developed by Ward in 1923. The addition of accelerators such as zinc acetate gives the dressing a better working time. Zinc oxide eugenol dressings are supplied as a liquid and a powder, so they come in two tubes. There is a liquid and a powder which are mixed before use. Eugenol in this type of pack can induce an allergic reaction which can produce reddening of the area and burning pain in some patients. So here also there could be some hypersensitive reactions. So you should be careful when you're doing the pack. Also make sure that you're ready for a reaction as well. Okay, so this is zinc oxide eugenol packs. Now we come to the non-eugenol pack. So we are using non-eugenol pack in our daily practice. The reaction between a metallic oxide and fatty acid is the basis for co-pack. So the other one is called as zinc oxide eugenol pack is called Wonder Pack, and this is called as a co-pack. This is also supplied in two tubes, the contents of which are mixed immediately before use until a uniform color is obtained. One tube contains zinc oxide, which is an oil for plasticity, a gum for cohesiveness, and loratadol, which is a fungicide. The other tube contains liquid coconut fatty acid thickened with colophony, resin or rosin, and chlorothiamol, which is a bacteriostatic agent. So this dressing does not contain asbestos or eugenol, thereby avoiding the problems associated with these substances. That is why we are using a co-pack, because eugenol usually can give you allergic reactions. So we're using a non-eugenol pack, okay, which is co-pack. Now, how do they help in retention? Now, how do we help retention of these packs? Periodontal dressings are usually kept in place mechanically by interlocking in. So whenever you apply the pack, make sure it's locked into the interdental. From both sides, it should be buccally and lingually, it should be interlocked by pushing the pack into the interdental spaces and also joining the two ends, that is the lingual and the facial portions of the pack. In isolated teeth or when several teeth in an arch are missing, retention may be a little difficult. So numerous reinforcements, splints, stents for this purpose have been described. The placement of dental floss tied loosely around the teeth can also enhance the retention of the pack. So this is an important part of your general surgery chapter. There should be an essay. You have to prepare an essay on periodontal plaques, rationale of periodontal plaques, classification of periodontal plaques, and which is the one which we normally use, and all their advantages, disadvantages. So if possible, when you're listening to this, make sure that after your class is taken, after you finish referring, you write a small essay on periodontal plaques. And this is a common short question. Now, what are the other properties of these plaques? It has got antibacterial properties, improved healing, patient comfort with less odor and taste, which has been incorporated by antibiotics. There is because antibacterial property means it has got antibiotics, right? The emergence of resistant organisms and opportunistic infections has been reported sometimes. The incorporation of tetracycline powder into the co-pack is generally recommended, particularly when long and traumatic surgeries are performed. Contact allergies to eugenol and rosin have been reported. So everything has a disadvantage, pro and con. So try to list out what are the pros are that it has got antibacterial properties. It will help in the improved healing and the patient comfort where there is no odor and taste difference. Okay, but sometimes there is an emergence of resistant organisms and opportunistic infections by usage of periodontal pack. And sometimes they say that you have to incorporate tetracycline powder along with the co-pack, especially for long and traumatic surgery, and contact allergies have been reported. Now, how do we manage post-operative pain? So we finished with your co-pack. Now coming to pain. According to Carranza, a pre-operative dose of ibuprofen, already I mentioned before, ibuprofen 600 to 800 mg can be prescribed, followed by 1 tablet 400 mg every 8 hours. Okay, you have to give a pre-operative. Before the surgery, you give him 1 tablet 600 to 800, followed by 1 tablet 400 mg every 8 hours for 24 to 48 hours, which is very effective. Post-operative pain related to infection should be treated with systemic antibiotics. So where antibiotics is required, you give antibiotics. But if the patient is a little apprehensive and which is an acute infection, we can give an ibuprofen pre-operatively and then follow it every 8 hours for 48 hours. Effective, will be effective. What are the post-operative instructions? That is, after the surgery, you're finished with it. Now you're going to explain to the patient what you have to take care. Instruct the patients to take 2 paracetamol tabs every 8 hours for first 24 hours, but do not take aspirin. Don't brush over the pack. Wherever the pack is placed, make sure that the patient does not brush. Instead of that, he can rinse with 0.12% chlorhexidine gluconate twice daily until the normal plaque control technique can be resumed. He can brush elsewhere at the other quadrants, but that particular area should be avoided, and instead of that, he can use a post rinse with chlorhexidine gluconate. Avoid hot foods during hot food during first 24 hours. Try to chew on the non-operated side. Okay, not the operated side. Try to chew on the non-operated side of the mouth. Avoid alcohol, citrus fruits, juices, spiced foods. Don't smoke. Swelling is normal. If the swelling is persistent as you go home, apply ice intermittently. Don't keep placing it. Keep it in for count for 20 seconds, then remove 20 minutes intermittently. We can apply ice. Pack should remain at least for a week. So these are the post-operative instructions we will give the patient. So we have come to the end. Now these are the things that you need to tell the patients post-operatively. So I'll just repeat what was the rationale for the periodontal surgery. We need to access the root preparation when your non-surgical methods are ineffective. We can establish a favorable gingival contour with the help of a surgery. We can facilitate self-performed oral hygiene, lengthen the clinical crown in case of crown lengthening procedures, and to regain lost periodontium using regenerative procedures. So I'm just repeating what was the rationale for doing the surgery. Okay, and what were the things that we looked before surgery, during surgery, and after surgery. And now, what are the basic principles you have to follow for proper healing? Adequate anesthesia, I've already mentioned. Patient should be comfortable, you should be comfortable. Adequate anesthesia, surface disinfection, very important. Sharp instrumentation, minimal atraumatic tissue healing, short operating time, preventing unnecessary contamination, proper suturing and dressing. okay, and followed by proper instructions, post-operative instructions, can give you a much positive surgical outcome. So these are the things that you keep in your mind, keep a tab next to you, write it down that these are the things that you need to achieve after these are things you need to keep in uh, mind before you attempt and after you attempt a surgery. So this will give you a positive outcome. So I hope this chapter it's a very interesting chapter, but there are a few questions that can be asked, especially on packs and even on sutures. So try to make a note on that pack, and when I take the class, I will discuss a little more briefly about it. Okay, so thank you for listening. So, and if you have any doubts, I will be taking a class on Thursday, most probably. So you can let me know if you have any queries. Okay, thank you.